Hey everybody, welcome to UroNurse. Hold the phone. This isn't UroNurse. This is big news from UroNurse. I don't dress up like this for UroNurse, but I'm launching a brand new podcast, so I thought I'd get a little fancy. That's right, folks. UroNurse News will be streaming live on StreamYard, YouTube, Facebook, LinkedIn, X, and Kick. And it's coming to you every Monday through Friday, 5 days a week. And at 9 a.m. Central Time, 5 days a week. Can't get too much of us, can you? Well, can't join us live? No problem. All of our episodes are available on demand at our new website. That's right. Our UroNurse News will be on our UroNurse website. You click the link, it'll bring you right over there. Or you can put it in yourself, uronurse.com/news with a capital N. And you can watch us then anytime, anywhere, on demand. What a beauty of a website, huh? UroNurse News, your go-to source for the latest in urology, health, headlines, clinical updates, and more. Now, mark those calendars. It all starts on August the 4th. That's our launch day. And that's no coincidence, by the way. You know, we're celebrating 3 years of UroNurse. It started on August the 4th, 3 years ago, by taking our commitment to urologic education to the next level. So I hope you'll join us every day starting August 4th for UroNurse News. Credible, current, and clinically sharp, just like I am. It's news worth your time. Okay, you heard it here first. UroNurse News coming August the 4th. So what do you think? Good idea? Great idea? I'm crazy.
I think it's great. I think it'll be interesting to see how it takes off. I hope everybody who joins us routinely can take a look at it for sure.
Yeah, of course, being completely retired, not having to go into an office anymore, I have more time on my hands, but I'm always reading these news articles that come through from urology sources. And I got the idea, it might be more fun if it was something that you could, watch a little episode. So these are all like 5 minutes or less snippets, so they're not really long. But I'm going to take a commitment and make it Monday through Friday. So I'll try my, threads as a newscaster, news anchor.
Yeah, you look pretty sharp there, Vic.
Yeah, I lost the tie and jacket for the show. I like to hear them, especially with this heat. We got the heat coming through, so definitely much nicer. So glad you could join us because I thought it'd be fun. I see we got some comments coming in from our group here.
Lots of good mornings today.
Stormy Chicago. Good morning to Susie Swain, Diane from Seattle, and Katie from Illinois. Welcome to Illinois. I'm sounding like now I'm really sounding like
now you don't live here. So.
I don't live here anymore. I can ruin the name. Well, thanks. How have you been watching these sexually transmitted disease updates that we've been doing for the last 3 weeks?
Yeah.
I thought it's really a nice review, so it kind of filled in. The summertime is not our heaviest viewership, so I thought, well, something that would be useful to have, especially something people would probably watch later on. And this one just fit perfect. So they're 3 in a row. This is the last one, so let's roll it right now.
So welcome back to Module 2, Part 2 of Sexually Transmitted Infections, Essential Knowledge for Healthcare Providers. I'm Kirsten Trudeau, and this is another presentation from the Kentucky Infection Prevention Training Center. Funding for this presentation was provided by the Kentucky Department for Public Health. Content includes discussion of unlabeled use of products. I have no financial interest or other relationships with the manufacturers of products, and no commercial support was provided for this educational activity. So our objectives today are going to be to identify and describe mpox, bacterial vaginosis, and vulvovaginal candidiasis, determine appropriate screening, testing, and treatment for each infection, review STI screening and testing sites for each infection, and discuss prevention methods including safe sex, prophylaxis, and vaccines. So we'll start off with mpox. So this is caused by the monkeypox virus, which is an orthopox virus. And in May of 2022, there was an outbreak of clade 2 mpox with person-to-person transmission. Clade 1 is historically more severe, and clade 2 is historically less severe. And this not just through sexual contact, it is spread through other means. So this is why it is important. It is important to do a thorough sexual history, but also a travel screening with all of your patients. Incubation of mpox is 1 to 2 weeks. They are not contagious at that time, but does require monitoring for up to 21 days. And this is just a nice graph from the CDC, kind of showing the different cases, or the cases of mpox since January 1st, 2024. So you can see that there are a total of 90 locations and 61 locations with only clade 2, 12 locations with clade 1, and 18 locations with both clade 1 and 2. So mpox signs and symptoms, so they may have a prodromal symptoms like fever, malaise, headache, sore throat, cough, lymphadenopathy, just generally not feeling well. But then more characteristically is this vesicular pustular rash that you can see here in the pictures on the right. Diagnosis for mpox involves testing with a PCR analysis. So they get samples from an active lesions or infected areas on the body. And it's very important not to unroof these lesions when you're getting a sample. It's not necessary for an adequate sample. And also there's too many risks with transmission when unroofing these mpox lesions. So you can see here the progression of these lesions. They'll start as macules, papules, moving to vesicles and pustules. And then by day 7 to 14, they start to crust over. And then by day about 14 to 28, they are healed. And it's important to note that patients with mpox are contagious until the scabs are healed and new skin is present. So for mpox treatment, it's typically supportive care with pain control, and there are not any current approved treatments for mpox, but there are some severe manifestations that might require further therapies. The CDC does have some interim guidance available on this, but it is important to note that mpox is not a lifelong condition. Now, to prevent mpox, there is the Jynneos vaccine, which is a 2-dose vaccine available, protects against mpox and smallpox. So who should get this? Anyone who has an increased risk or exposure to someone with mpox, a sexual partner with mpox, any gay, bisexual, or other men who have sex with men with a history of STI in the last 6 months, or if you have more than one partner, anyone with having transactional sex, any large or commercial event or an area with mpox virus transmission, if someone is attending one of those events or traveling to an area like that, traveling to a country with clade 1 outbreak and planning for activities of increased risk, or any occupational risks. Also to note, if you have recovered from mpox, vaccination is not recommended. So bacterial vaginosis, we'll move on to BV. So bacterial vaginosis is a type of vaginitis. Vaginitis can be caused by many different things. It's not necessarily an STI, but it can be associated with sexual activity. So BV is a type of vaginitis where there's a disruption of the normal microorganisms like the hydrogen peroxide and lactic acid producing lactobacilli in the vagina. So some of the anaerobic bacteria start to come in high concentration. You'll see G. vaginalis, Prevotella species, Mononucleus species, and A. vaginae. It is the most common cause of vaginal discharge. It's associated with sexual activity, higher prevalence during menses, and there is an increased risk of other STIs. So BV diagnosis would include a gram stain or wet mount prep of vaginal specimen. Would also use the AMSL criteria, would be used for clinical diagnoses, which would, the criteria for this is homogeneous discharge on the vaginal walls, looking thin or milky, having a pH of the vagina greater than 4.5, having a positive whiff test, and at least 20% clue cells. And below in this picture, you can see an example of a clue cell. Treatment for BV is metronidazole, 500 milligrams orally 2 times daily for 7 days, or metronidazole gel, 0.75%, 1 full applicator intravaginally once a day for 5 days, or can do clindamycin cream, 2%, 1 full applicator, 5 grams intravaginally at bedtime for 7 days. There are also some alternatives if those are not an option, which you could refer to the CDC STI treatment guidelines for that. So bacterial vaginosis, is it an STI? So as we discussed, there are many different things that can cause vaginitis. And with bacterial vaginosis, it is really difficult to treat and not have a recurrence. And so this article recently came out in the New England Journal of Medicine on March 5th, 2025, discussing male partner treatment to prevent the recurrence of bacterial vaginosis. And so we just want to be really careful not to classify bacterial vaginosis as an STI as a result of this article. While it may seem that it is associated with sexual activity, by treating the male partner, likelihood of reoccurrence did go down in this particular study, but it was a small study, and I think more research needs to be done, and we just need to be careful when we refer to this as an STI, because it kind of creates a stigma around bacterial vaginosis, where someone may not have had bacterial vaginosis due to sexual activity, and may have people less likely to seek treatment for this if it is classified as an STI. Vulvovaginal candidiasis, we'll move on to this. It's typically caused by Candida albicans, and it can be caused by other Candida species as well. But 75% of women will have one episode, and about 40 to 45% will experience 2 or more episodes. And some signs and symptoms include external dysuria, vulvar pruritus, pain, swelling, redness, fissures, thick, curdy vaginal discharge. Diagnosis can be clinical plus a KOH wet prep or a culture. The KOH wet prep would show budding yeast, hyphae or pseudohyphae, and you can see that in the picture below. And then a culture would show yeast species. You can see here that the treatment for vulvovaginal candidiasis there are lots of many recommended regimens for this, which are over-the-counter intravaginal agents. So I won't go through all of that, but there are all of these options listed. Some things to know about these creams is they could weaken diaphragms and latex condoms when using these creams. And if it is severe, it may require more intensive treatment. So if it's a non-albicans candida, treatment's difficult, and you'll want to follow the CDC STI treatment guidelines for next steps, including all of the other reasons for vaginal symptoms. With pregnancy, only topical azoles for 7 days is recommended. With persons with HIV, while Candida colonization is higher in HIV-positive women, treatment does remain the same. Now, management of sex partners. So for uncomplicated cases of vulvovaginal vaginitis, usually they're not sexually transmitted, but the caveat for this would be any male partners with symptoms. So if they're having balanitis, erythematous glands of the penis, plus pruritus or irritation, they could benefit from some topical antifungal treatment for that symptomatic treatment. And I'm not going to go too far into human immunodeficiency or HIV in this module because we have 3 separate modules on our website that does a deep dive into HIV. That is a wonderful set of modules. So we have one on HIV transmission, pathogenesis, and diagnosis, and then the introduction to HIV, pre-exposure prophylaxis, and then general principles of HIV treatment that you can see on our website. But just to note, the HIV screening recommendations, these are also from the CDC laid out by women, pregnant women, men who have sex with women, men who have sex with men, and transgender and gender diverse persons. So complications of untreated STIs, there can be effects on fertility, pelvic inflammatory disease, increased risk of some cancer, disease spread to partners, which is a public health concern as well, increased risk of HIV and transmission to fetus and neonate. So when it comes to testing, more recently, we have started learning more about extragenital testing. And this is a nice study from Friedman and O'Brien discussing extragenital testing increases case detection of gonorrhea and chlamydia, the impact of implementing nucleic amplification testing. So this study showed that there was an increase in the detection of gonorrhea and chlamydia, particularly in men who have sex with men, by doing extragenital testing. So this study found a 4-fold increase in gonorrhea detection and 2-fold increase in chlamydia detection exclusively at extragenital sites, being the pharyngeal and rectal sites. Self-collected specimens. So self-collected swabs can be vaginal, oropharyngeal, and rectal, and self-collected swabs are safe, effective, and preferred. Urine samples from males to screen for gonorrhea can be left at room temperature for several days, ideal for people who are refusing examinations, and then 97% of people would visit an STI clinic again if self-collected rectal swabs were a standard practice. And there recommendations for published guidelines on self-collection. We do need further recommendation for these published guidelines on self-collection instructions. Some education from different handouts that you can give to patients on how to perform STI self-collection. You can see here these images. There's an image and instruction for rectal, oropharyngeal, as well as vaginal self-swabs. Expedited partner therapy. So for expedited partner therapy, or EPT, this is a clinical practice to treat sexual partners of infected patients, specifically with gonorrhea and chlamydia. So prescriptions are provided to the patient to take to their partner, and the healthcare provider does not have to examine the patient first. And this prevents reinfection and further transmission. And this is particularly useful for the treatment of male partners in a relationship with a woman who is positive for gonorrhea or chlamydia. So is EPT legal in my state? So you can see that almost all states that EPT is permissible, with only South Dakota, Kansas, and Oklahoma being potentially allowable. So definitely check your state regulations when it comes to EPT, but it is certainly effective in reducing the transmission risk if it is permissible where you live. Other prevention strategies would be abstinence, vaccination like hepatitis B and HPV, reduction of sexual partners, so limiting that sexual network that we talked about, screening routinely, having mutually monogamous relationships, protection, using condoms correctly every time, knowing your status and the status of your sexual partners, and then the use of PrEP and DoxyPrep as appropriate. So what is DoxyPEP? DoxyPEP is the recommended population for use is gay, bisexual, and other men who have sex with men and transgender women having a history of one or more bacterial STIs. Those who have not had an STI may still benefit if they have an increased risk of infection. You also would have to do follow-up visits every 3 to 6 months, HIV screening every 3 months, gonorrhea, chlamydia, and syphilis screening every 3 to 6 months, and you would provide enough doses based on frequency of sexual encounters. So when you're providing DoxyPEP to prevent STIs, you would discuss DoxyPEP with those who would benefit most. You offer and write a prescription for the patients to self-administer 200 milligrams of doxycycline within 72 hours after sex, with enough doses to the follow-up visit, and offer DoxyPEP in the context of comprehensive sexual health approach. And so this DoxyPEP has been proven to reduce the risk of some STIs for some gay, bisexual, and other men who have sex with men and transgender women. Of course, if there is an allergy to Doxy, that is a contraindication, which you would want to follow up with the infectious disease specialist to determine if there is an alternative. So key takeaways here, screening can capture asymptomatic infections for treatment. Self-collected testing is proving to be effective and preferred in many cases. Extragenital testing is capturing more positive cases at different sites, which may have not been otherwise detected. And left untreated, many STIs can have detrimental implications. There are also more prevention strategies than just abstinence, which I think is very important when you're talking to your patients, educating your patients, having that open, judgment-free conversation when you're trying to figure out what prevention methods and strategies will work best for them. And at the end of this module, I just want to pull all of this together to say that having open, judgment-free, bias-free dialogue with your patients is going to lead to the best sexual health for your patient and the best outcomes. So taking the time to have those conversations, asking questions when you don't understand something, being open and non-judgmental to the things that they are telling you, and providing all of the options for prevention to them instead of just saying abstinence or condoms. All of these things will improve the sexual health of your patients. And these are my references. And feel free to follow us on social media. And thank you for joining for this module.
There we go. We've now completed everything you should have to know about sexually transmitted infections. So there's a few things in there that was interesting. Have you ever heard of the whiff test?
No.
Yeah, of course, I had time to look it up while we were listening to the show. And actually, you take a sample from the vagina with a swab and put it on a slide, and then you add potassium hydroxide to it, which was what they did to look for the other thing. And then you smell it, and if it smells fishy, that's positive for vaginitis or whatever that was. Vaginosis. Thank you. Hey, you learned something new here on UroNurse. I did see some questions or some comments come in, and I saw a lot of people that have joined since the show started. So you may have missed the big announcement. I told you it was starting. So Katie wanted to know what time, because she missed what time it was going to be on. So for those of you that don't know about it, let me see if I can bring up the real quick here. I try to share. Yep, here we go. So there's the website. Hopefully you can see that. And so launching August 4th. Do you realize that we've been doing this for 3 years?
That's crazy.
I mean, it was like a crazy idea that we kind of sat down and started talking about and decided, I said, somebody will help me. And you and Andrea volunteered. And 3 years ago, we got this thing rolling.
I've learned a lot.
Yeah. And I've heard that from a lot of people, a lot of feedback about how much they learn. They use it to study for certification. So UroNurse isn't going anywhere. I love putting this on every week. So looking forward to a lot of great episodes in the future. But I decided, to start something new in case you're new and didn't catch the morning. It was a new website, UroNurse News. It's part of UroNurse, so it's on the UroNurse site. It will be anyway when I get off the show today. I'll make that active. So you'll be able to read more about it and see what's coming up. But you'll also see what's going to be playing every week, because it's going to be one of these things that I'm going to have a little 5-minute news show. And as you can see me up there in that suit coat, I'll be dressed a little fancier than I am right now to put on this show. But just covering all sorts of, mostly urology, but all sorts of medical things. There's a lot of interesting stuff going on out there. If you don't keep up on it, it's going to leave you behind. So we'll share all those stories. People have stories they want to submit and send to me. Feel free to do that too. There'll be a button on there to send information to contact me. So let's see. We do have some comments. Oh yeah, and I keep forgetting to answer Katie's question, which is, what time is it going to be at? 9 a.m. Central Time. What other time would it be?
Keep it consistent.
All right. So let's see. We got some more folks coming in from California. Charlene, amazing 3 years. Yes, every week I learned something new. Charlene's been with us, I think, the whole 3 years. Mm-hmm. So it's great to see a lot of fans that have stayed with the show. And Nisha said, "Whiff, we used to do it years ago." Yeah, I'd never heard of it. So I was kind of curious myself to see what it was. And it is a smell you can't forget. Well, maybe I'm glad I didn't know. Maybe I'm glad it isn't something I knew about. Let me see. I'm going to get this. Let's take this off the screen. There we go. Yeah, I guess so. It's a smell you can't forget.
It's almost like going to work, and when you've got smelly urine and you feel like you smell it on you for the rest of the day.
Oh yeah,
to go home and take a shower.
Some of those badly infected catheters, and it's
yeah.
And thanks to you, King. I don't know if I'm saying this right, King Wang. I think I got the Wang right. Thank you. Learn something new every week. It's amazing. So yeah, you guys are the reason we keep coming back every week and doing this, because if there's nobody watching, there's no sense doing it. I mean, it's fun to do, but it's been a ride. 3 years. It's really good. So, and I'm glad to have help, because sometimes, doing this on your own is trying to come up with questions and things to talk about is difficult. And Lori's always the best one to have, just to kind of keep it real. And you're not retired, so you're more current than I am.
No, I'm not retired. I got a ways to go still.
Yeah, we got more comments coming in. Nisha said, "Nice review. Thank you." And daily news sounds great. Good. I'm hoping that we'll see how that goes. See if people are watching it. Again, if it's successful, I'll keep doing it. I've got a huge list of news stories to read through and to produce. It's going to be a lot different because they're going to be pre-recorded, so it won't be coming on live, although I'll release them like a live show every morning at 9 o'clock. But I've got a little different format and stuff, so I'm sure evolve like anything else. Question: how to prepare for certification tests? Urology nurse practitioner. What do they say? Practice, practice, practice. I think this is a good preparation for it. They SUNA has their own textbook, adult. I can't remember what it's called right now, but you can buy it. And that's a great study guide. They also offer some study guides on taking the test. Now, Lori and I both went through not the nurse practitioner side of it. We took the RN, CURN. And Lori, what did you do to prep for it?
Oh boy, that was a long time ago when we did it in paper and pencil. I think that just going over, it's almost like when you're in school to get your NP or nursing or what have you. I think that just constantly asking questions and answers, questions and answers, questions. And they do review pretty much everything. Physiology and anatomy was big. I'm trying to think of if you've been in urology for a while, chances are you're going to do pretty good, because if you're specialized in it, I think that's why they have those. I think they still have the rules. You should be in urology for a year or what have you. They have some criteria that you have to meet. But Whew, a lot of praying, I guess. I don't know.
Prayer is always good.
It was a tough test for me, but that was a long time ago. So I don't know how it is now.
But
But
I think you're right. If you're in the field and you're practicing on a daily basis, what you know, think about what you know and answer the question with what you really would do. Most of the time, you're going to be right. And my whole trick to taking tests, and I'm actually I think a pretty good test taker, is I make my decision, I put it down, and I never go back.
or
Because
pick
as soon
B.
as
Pick
yes,
B.
as soon as you start thinking through, and then it's like, well, could it be? Because they say, on a multiple guess choice, two of them are clearly wrong. Two of them are hard to figure out which is right. So you got a 50-50 shot. And what'd you say? Pick B?
Pick B. I don't even know how it is now,
But yeah, that's I took a long time ago, took the certification test. And as you said, back then it was paper and pencil. And then in the old days, to recertify, you had to either take the test again or do this some kind of a module presentation or something. It was crazy. And to me, it was easier to take the test again than to do that. So I took it twice.
that must have been a long time ago. I really recommend getting your continuing education because I don't want to take that test again.
Yep. Much easier. And you have to have somebody in urology and all the stuff that we're putting through here.
Right.
Last year I counted up, we had, I think, 13 hours of continuing education in urology subjects. And you only need, I think, is it 20
well,
no, 20 is for the state of Illinois.
It used to be 50 for recertification for nurses anyway.
Yeah.
And then they and now it's 36. And, even if you're like a SUNA member, they offer a free credit every month. So if you keep up on those credits, you're going to get your 36. And you know what, that's part of the reason why I go to the conferences too. Because the conferences are big. You get a lot of credits that way too. Yep,
absolutely. All right. Well, it's been great doing this review on STIs. And hey, everybody, don't forget about that coming August the 4th. Watch for it to be on the website. I'll probably be throwing a lot of reminders out there too. But next week, we've got a regular speaker coming in for a regular show. And here's what it's about.
Pluvicto is changing the landscape of advanced prostate cancer treatment. But is it right for you or someone you love? In this must-watch episode, host Vic Senese sits down with prostate cancer expert Dr. Elliot Siegel to discuss the real-world use of Pluvicto. We will discuss the radiopharmaceutical industry and where it's headed. How therapies like Pluvicto work, who qualifies, what to expect during treatment, and how it's impacting survival and quality of life. Join us on July 26th at 9 a.m. Central Time to learn more.
So there you go. Have you heard of Pluvicto before?
I've never heard of Pluvicto, so that'll be interesting.
Okay. Makes me feel better because there are so many products that are coming out down the line right now that it's just amazing to try to keep up with it. So I've been getting a lot of speakers on a lot of new things that are out for prostate cancer treatment. So good stuff to watch. All right, everybody. Well, have a great weekend. I hope the storms hold off a little longer because I've got friends coming over for a picnic. So otherwise, hopefully see you next week, Lori. And the rest of you,
sounds good.
See you next week.